Welcome to this virtual press conference hosted by the American College of Surgeons during our 2020 Clinical Congress, which is also a virtual-only event. Before we begin, I'd like to remind you that all attendees will have their mics muted during the session, but the chat feature remains open should any attendees wish to pose a question to one of our study presenters after they've concluded their remarks. This afternoon, an educational session for Clinical Congress attendees was held to address the issue of addressing the social determinants to reduce firearm violence. This press event immediately follows that session, which is the first to publicly introduce a new task force from the American College of Surgeons Committee on Trauma, ISAVE. With us today are three of the panel's presenters. Dr. Ronald M. Stewart, Medical Director of ACS Trauma Programs, Dr. Eileen Bulger, Chair of ACS Committee on Trauma, and Dr. Rochelle Dicker, Chair of the ISAVE Task Force. Their clinical leadership roles and professional affiliations are shown here. And now, to lead off our session, is Dr. Ronald Stewart.
Thank you, Ms. Garneski. It's a pleasure to be on this press conference. That was a terrific panel, and I'm personally really grateful to the leadership of everyone on the ISAVE task force for all they're doing. But just a little bit about the problem and how we came down this path. First of all, it's a really important health problem. There's almost 67,000 people die each year in the United States from intentional violence. So that's self-harm or an assault. That translates into 183 deaths every single day. 183 people die every day. Of those, you can see that 72% are suicides. And of those, about half, 51%, are firearm related, and 28% are homicide, assault related. And about 3/4 of those are firearm related. So there's a total of intentional death in the US that about 57% involve a firearm. And since 2017, more people die from firearm related injury than motor vehicle crashes in the US. And you can tell from the panel discussion that was just held that the burden of the disease is much greater than deaths. Communities are impacted. Patients are traumatized, which have other health consequences. So it's a huge problem. Next slide, please. As we began it's probably been about 5 or 6 years ago now, we started working on a common approach to reducing firearm injury. And we surveyed surgeons, we've talked to surgeons, we've had town halls, and I think we've really shown, at least in a group of very strong-willed, opinionated people like surgeons, we've shown that actually people can really work together across regions of the country and across philosophical differences. But in the beginning, we realized that there's two common stories that we tell ourselves as Americans. One we call the firearm and freedom narrative, which goes something like this: that firearms are generally beneficial, they're necessary for personal protection, they're a constitutionally protected right, and really for that person, gun control translates into freedom control. On the firearm and violence narrative, about 40% of people hold each of these views. The firearm and violence narrative goes something like this: that firearms are generally harmful, they're generally unnecessary in modern civil life, and they actually decrease personal liberty because of increased risk of harm. And for the person who holds that closest to their heart, firearm is an emblem of violence. So gun control translates into violence control. But as we started talking, as we worked with each other, we realized it is possible to have a common story around these things. And so working together across these different stories and philosophies, we realized that, well, you can have an inclusive narrative which goes something like this: that firearm ownership is a constitution protected liberty, but we really have a big violence problem with a lot of preventable death and suffering, as the previous data just showed. And how we can best address that is to work together to make firearm ownership as safe as possible, but also to understand and address the underlying causes of violence. And the great panel discussion that we just had is one of those strategies. It's working to understand and address the underlying root causes of violence. And so a part of that is partnering with communities and community leaders across the United States to really address social determinants of health. With that, I'll turn it over to Dr. Bulger.
Thank you, Dr. Stewart, for that great introduction, and to pick up from that background. Really, the next thing we did was convene a medical summit in February of 2019, which brought together the entire House of Medicine. All subspecialties were represented, along with the American Bar Association, to really delve into this issue of how could we take a practical approach to solving the problem of firearm injury in the U.S. And if you go to the next slide, please. So this graphic shows a summary of the outcome of that summit, which includes a series of consensus statements that all of the organizations agreed to, really focusing on this as a public health problem requiring a public health and medical approach rather than a political approach, and a roadmap for interventions that could be done to address firearm safety. As a result of this, we appointed two task force, one, the Firearm Strategy Team, which is a group of firearm owning surgeons working on firearm safety initiatives, and the ISAVE team, which is working on the social determinants to attenuate violence. When we talk about the social determinants of health, we're talking about social economic factors, things like education, employment, housing, stable home environment, all the things that are important to an individual's health as they integrate with the community. And this has been reported to account for a huge amount of the factors that contribute to health outcomes and equity. And so these are really critical, important issues in our society and deserve extra attention. This is a picture of our ISAVE team. It's a truly multidisciplinary team, not only including trauma surgeons and emergency medicine providers who are on the front lines and caring for victims of violence, but also multiple other specialties, including pediatrics, internal medicine, our public health colleagues, mental health specialists, and epidemiologists, and importantly, engaging community workers and community advocates and law enforcement as it relates to community policing. So a truly phenomenal group that's working hard on developing issues that we can practically implement through our trauma centers. So I'm going to introduce you to Dr. Dicker, who's the chair of the ISAVE team, and she's going to go over briefly some of the work that they're doing.
Thank you, Dr. Bulger, and I just want to thank Dr. Stewart and Dr. Bulger for their incredible leadership and vision in making this happen. We got an opportunity to meet right before COVID hit us, where the ISAVE group came up with 4 different themes that we would focus on. And the first theme is to develop a nimble curriculum for trauma-informed care. And trauma-informed care is a recognition that trauma is a lot more than the physical injury for that patient who is in front of us in the moment. That people from communities at risk experience trauma on an ongoing and chronic basis. But to normalize it in our trauma centers and not have a sensitivity to that is just wrong. And we can fight against that by our own recognition and appropriate response to the fact that people are traumatized over and over again. And so we're developing a curriculum, and we will pilot that in several of our trauma centers across the country, hopefully in the early 2021. The second is to create a roadmap for the investment in at-risk communities. Where there is wealth, there is health. And for a long time, there has not even been access to investment and to financial security in many of our at-risk communities. So we're building a roadmap as to how a trauma center can get involved in investment. And then we're going to talk a lot about the integration of social care into the trauma system. And this is absolutely essential. As Dr. Bulger had mapped out, 40% of social determinants make up the overall impact of our health. And so programs such as hospital-based violence intervention that target really social determinants and risk factors to violence are going to be a big focal point in integrating social care. And then finally, there's this overarching idea of advocacy, and that is, what is a trauma center's role and the personnel in that trauma center around advocating for these elements to bring about equity, particularly as it pertains to violence. And I would put forth that now is the absolute perfect time for the ISAVE initiatives. Where there is adversity, there is opportunity. And what do I mean by that? Well, our social justice movement includes a focus on health. And COVID-19 really highlights that, how we really need to build in and mitigate these health inequities. And in violence, the health inequity is absolutely off the charts. Schools and hospitals right now nationwide are building efforts in health equity. At UCLA, where I work, there is an anti-racism roadmap that's going on in the part of the leadership there. And healthcare systems are looking, the whole system is really looking for solutions at a very high level and at a granular level in communities. And so we at ISAVE are ready to say, look, these are our ideas around solutions. Some of them are tested, some of them need to be tested further, but we can show you how to make this happen in your particular healthcare system and in your trauma center in particular. Thank you very much.